If we are not live, just let me know when I'm live. First, I'll share the screen and then tell me when we are live.
Yeah, I had made it live. You can start.
Okay.
Should I start now?
Wait. Yeah. I'll just introduce and then we can start.
Okay.
Okay. So, yeah. Good afternoon, good evening, everyone, and welcome for this evening CME meet. On behalf of Samarth Life Sciences, I welcome you all. My name is Dr. Sanjay Kamble, and I'm heading the medical team here at Samarth. It's my privilege to be associated with such medical activities. It's my duty to share about Samarth Life Sciences in a brief before we start the sessions. So our vision is to be an innovative global healthcare company which adds life to life, and our mission is to be a proud heritage, passionate company committed for innovative and differentiated products that we make in India. The group started a long time in 1963 with a humble beginning by Mr. Gulwant Lal Shah, and now it has today grown into a multinational company that exports our products to various countries in South America, UK, Southeast Asian countries, and many African states. We have global presence everywhere in most of the countries. To enumerate few, we are in Asian countries, Middle East, Russia, UK, Poland, and Spain. With our differentiated products, we cater to more than 35 such countries. So we have two formulation plants that cater to various requirements. One is and also an R&D center at Bangalore, wherein we manufacture critical care products, lyophilized, anti-cancer formulations, hormonal injections, tablets, and creams. So our aim is to grow exponentially into multiple therapies, and for that we have a robust marketing teams, which includes 10 leading divisions which cater to various specialties, of which Conquest is one of them. So for today's meeting, it's my privilege to have a group of allied speakers who will be talking on various topics. So we have Dr. Jivan Kumar Garg, sir, who is a senior consultant at Department of Clinical Hematology and Cellular Therapies at Tata Medical Center, Kolkata. Sir has an experience of 10 years in this field of oncology, and he has been a part of various publications, theses, and researches, and has did multiple paper presentations in national and international conferences. Welcome, Dr. Jivan Kumar, sir. Again, it's my privilege to welcome Dr. Demalya Bhattacharya, sir. Sir is from SCB Medical College, Cuttack. He has a vast experience of more than 14 years in this field. He's a consultant at Department of Hematology and BMT, Apollo Hospital, Kolkata. He has been the ex-consultant at Saroj Gupta Cancer Center and Research Institute, Kolkata. I would also welcome Dr. Priyanka, ma'am, who will be joining shortly with us for this meeting. Madam is the professor and department head at Clinical Hematology and Hemato-Oncology, IMS and SGM Hospital, Bhubaneswar. She has been associated with SGCCRI hospitals, Apollo Clinics, Kolkata, and her area of interest includes hematological malignancies, sickle cell diseases. Madam has contributed to more than 41 publications in various national and international journals, and her research activities include acute myeloid leukemia, myeloma, sickle cell diseases. She has been the part of clinical trials on SCD, hematological malignancies, and has received award from Times Health Icon for excellence in hematology in 2023. And also various awards from various renowned bodies. Welcome, Dr. Priyanka, for today's meeting. Also, I would welcome Dr. Kusumita Roy Mandal, who will be joining shortly. She is the assistant professor at CMCH Kolkata. Madam has been associated with various institutes throughout her professional careers, and she presently she is assistant professor at IHBT Medical College, Kolkata. Welcome, madam, for today's meeting. So with this, I would just shortly introduce the agenda for today. So today we have four talks. The first talk would be by Dr. Jeevan Garg on role of Acalabrutinib on CCL, followed by Dr. Deb Malya, who will be presenting on role of Acalabrutinib on MCL. And then a real world data will be presented by Dr. Priyanka Samal and followed by a case presentation by Kusmita Roy Mandal. So with this, I would also welcome all the delegates who have joined us for today's meeting. And also my colleagues from the marketing and sales and from the medical team of Samarth Life Sciences who are there with us. So with this, I stop sharing my screen and I hand it over to Dr. Jeevan Garg to start his talk on role of Acalabrutinib on CLL. Over to you, sir. I'll stop the present my slides.
Yeah, thank you, Dr. Sanjay. I will start my screen sharing.
Yeah, they are visible. You can make it full screen, sir.
So now screen is visible.
Yes, yes, yes.
Yeah. So good evening, everyone. I'm thankful to Samarth Life Sciences for organizing this webinar. So today my topic of talk is role of BTK inhibitors in CLL, mainly focusing on Acalabrutinib. So CLL is a lymphoproliferative disorders. So is it characterized by co-expression of CD5, CD19, CD20, and CD23. The difference between SLL and CLL is that in CLL we will find in the peripheral blood lymphocytosis. In SLL, patient will have mainly lymphadenopathy without any lymphocytosis. So in the epidemiology, the data suggests that the clinical presentation of CLL is different in Asian population as compared to Western population. So according to a study, so this is the data from US as compared to India. So the percentage of patients with CLL is much more in US as compared to India, and the percentage of all leukemia patient in US is around 31% patient have CLL as compared to only 4.3% patient of all leukemia in India have CLL. And in India, the presentation is also at younger age as compared to Western population, and majority of these patients may have aggressive course and they require early treatment. So according to International Working Group meeting in 2018, they have laid down the CLL guidelines for indication of the treatment. So these are the indications. So the main indication is the constitutional symptoms which are referred to CLL. This may be weight loss, this may be having night sweats, or if patient is having fever. If patient have progressive cytopenia, maybe having thrombocytopenia or anemia requiring blood transfusion, or hemoglobin if it is less than 10 gram. Or if patient has autoimmune anemia and along with thrombocytopenia, which is poorly responding to steroid therapy. Or patient have massive splenomegaly or massive or progressive lymphadenopathy. Or having extranodal involvement, which are causing symptoms in the patient. Or progressive lymphocytosis, which may be defined as increase in lymphocyte doubling time within 6 months. And if there is no such symptoms, then treatment is not required even in patients which have high risk CLL. So before starting treatment, what are our goals of treatment? So our goals are reasonable good control of the disease, because CLL is uncurable disease. We have to only control the disease, and the treatment should be cost effective with less financial burden to the patient. And depending upon the patient preference, we have to choose the treatment. It may be fixed duration treatment, it may be continuous treatment like BTK inhibitors. And depending upon the patient's toxicity, so we can change the treatment. And depending upon patient to patient, we can choose different treatment as per the patient's age or comorbidity. Like patient with cardiac issues or patient with high risk of bleeding, the BTK inhibitor may not be the good choice. And in the patient with high risk features like TP53 or IGHV mutation status, so these patients may require the BTK inhibitor or venetoclax type treatment. And if patient has toxicity with one treatment, we can change the treatment. So in the CLL, from last 50 years, there is a lot of change in the treatment. Previously, the only options are clorambucil or prednisolone. And after that, the rituximab came in 1997. Then the treatment of choice is FCR. And slowly, this treatment in unfit patient changed to bendamustine and rituximab. After that, ofatumumab and obinutuzumab also came, which were also tried in combination with bendamustine. And in 2014, ibrutinib was launched. And after that, many other BTK inhibitors like acalabrutinib and zanubrutinib, they are launched. So these become now first line of treatment. And recently, other treatments are also available, which may be the non-covalent BTK inhibitors or CAR T cell therapy. So these are the novel drugs and their targets. So different targets can be hit in a patient with CLL. This may be PI3 inhibitors. Although these are not the first choice treatment, but these are the treatment which can be given in a patient with relapsed refractory CLL patient. Nowadays, the first of choice of treatment is BTK inhibitors, which may be ibrutinib, acalabrutinib, or zanubrutinib. Other targets like monoclonal antibody, which are hitting CD20, this may be rituximab, ofatumumab, or obinutuzumab. CAR T cell therapy may be required in relapsed refractory patients, and they are mainly CD19 CAR T cell therapy. And the patient which have resistance to BTK inhibitors, the other choice of treatment is venetoclax, which is BCL2 inhibitor. This is the algorithm of newly diagnosed CLL patients. So first we have to confirm whether patient require treatment or not, depending upon the indications of the treatment. If patient require treatment, then we have to do the risk categorization depending upon TP53 status. So the patient without deletion 17p or TP53 mutations, we have to check the IgHB mutation status. If IgHB is mutated without deletion 17p, so that means patient has good risk without any poor risk features. These patient, if patient is fit, these patient can go with chemotherapy with FCR. And if these patients are not fit, then they can go with chemotherapy with BR. But these are the older treatment. Nowadays, in patient without TP53 mutation or without deletion 17p, ibrutinib or acalabrutinib can also be given with or without obinutuzumab or rituximab. But in the patient with deletion 17p or TP53, these patients have very poor response with chemotherapy. So the only choice is BTK inhibitor-based treatment or BCL2-based inhibitor-based treatment, that is venetoclax. So a little bit about the BTK inhibitors. So the BTK inhibitor is a cytoplasmic kinase belonging to TEC family. And this BTK is expressed in all the B cells and they are not expressed in the T cells. And in the BTK inhibitor, it may be covalent type, it may be non-covalent type. Previously, when first BTK inhibitor was launched in 2009, that was ibrutinib. This was approved by FDA. And after that, acalabrutinib and zanubrutinib was also approved. In patients which have resistance to BTK inhibitor, mainly covalent BTK inhibitor, the other choice of treatment may be non-covalent type. The pirtobrutinib, it was launched in around 2019. So this is still not approved by FDA, but this may be the future treatment. These are the FDA-approved BTK inhibitors. Ibrutinib, acalabrutinib, and zanubrutinib all are approved by FDA. Venetoclax is also approved by FDA for CLL. And the patient which have resistance to BTK inhibitor and also resistance to venetoclax, the non-covalent BTK inhibitor, pirtobrutinib, is in phase 3 trials. So what is ibrutinib? So ibrutinib is the first of its class. It was initially synthesized in 2007 and many trials are done with ibrutinib. So the first trial was Resonate 2. It was comparison of ibrutinib with chlorambucil in CLL patient. So this trial has shown that ibrutinib is showing better PFS and better OS. So after that, the ibrutinib was approved by FDA. After that, many other trials were also done. In another trial, ibrutinib with rituximab was compared with FCR in patients which have less than 70 years of age. That trial has also shown superior PFS and OS. Then another trial, Illuminate trial, it has compared ibrutinib in combination with obinutuzumab as compared to chlorambucil in combination with obinutuzumab. This trial has also shown a better PFS, and majority of these trials have shown that continuous BTK inhibitor monotherapy, it is showing better PFS. But still, there is doubt that whether adding BTK inhibitor with CD20 monoclonal antibody will give better PFS OS. So that question is still not answered. This is a trial of comparison of ibrutinib as a single agent and ibrutinib in combination with rituximab or rituximab and bendamustine combination. So this trial was done in patients which are having more than 65 years of age and the patient which are treatment naive. So this trial has shown that there is no significant difference between ibrutinib plus rituximab and as compared to single agent ibrutinib. But the difference in PFS is significant in patients which have received bendamustine and rituximab. So ibrutinib, although it is now as a first choice of treatment, but it has its own challenges. The main challenge is that it can cause main complication like hemorrhage, which can occur in around 40 to 50% of patients. Other main adverse event is the diarrhea and atrial fibrillation. So these complications are mainly depending on the selectivity of this BTK inhibitor. So like ibrutinib is very less selective, and as compared to acalabrutinib, zanubrutinib, which are more selective. So depending on the selectivity of the inhibition, the complication rate may be more. So like ibrutinib, because of inhibition of TEC and EGFR, it causes more complication. The second BTK inhibitor is acalabrutinib. This is a second class BTK inhibitor. It is already approved in CLL and mantle cell lymphoma. This is Elevate RR trial, which has done to compare the acalabrutinib and in ibrutinib in previously treated patients. So these are the relapsed refractory patients. So these patients have shown that the acalabrutinib and ibrutinib have shown similar efficacy. The PFS is almost similar. But according to adverse events are much less with acalabrutinib as compared to ibrutinib. So as you can see that the risk of bleeding, this is the all grade bleeding. So this is 51% in patients which have received ibrutinib as compared to 38% in patients which have received acalabrutinib. The second main difference is in the atrial fibrillation. So atrial fibrillation is also less with acalabrutinib as compared to with ibrutinib. After that, this is the 5-year follow-up of acalabrutinib as a single agent or acalabrutinib in combination with obinutuzumab versus obinutuzumab with clorambucil. So this is the PFS. So the patient which have received clorambucil along with obinutuzumab, the 5-year PFS was only 21% as compared to the group which have received acalabrutinib with or without obinutuzumab. They have shown very good PFS. And there is slightly difference in overall survival also. This is the phase 1, phase 2 trial of acalabrutinib in ibrutinib intolerant cohort. So as such, if patient has resistance to ibrutinib, then there is no benefit of changing that drug to acalabrutinib. But the patient which are intolerant to ibrutinib, we have the option to give acalabrutinib. So this trial has done on 33 patients and who are not able to tolerate ibrutinib. Out of this trial, 23 patients were remain on acalabrutinib and no acalabrutinib dose reduction was required in these patients. And of the 61 ibrutinib-related adverse events, 72 did not recur. So these are the adverse events in the patients which have received ibrutinib. So after changing the treatment to acalabrutinib, in around 72% patients, those adverse events were not recurred. The other agent which is this is also a second generation of BTK inhibitor, that is zanubrutinib. So this is also approved in various indications like CLL, Waldenstrom, mantle cell lymphoma, and also as a second-line treatment for marginal zone and follicular lymphoma. This is a trial which was Alpine trial done between zanubrutinib and ibrutinib in relapsed refractory CLL patients. So the patient which have received more than one prior line of treatment, so zanubrutinib was given as 160 milligram twice a day and ibrutinib was given 420 milligram once a day. And they have sufficient number of patients, around 207 in one arm and 208 in the other arm. Both drugs are continued till the patient has progressive disease or toxicity. This is the difference in PFS. So at 2 years, the PFS in the patient which have received Zanubrutinib was 79.5%. As compared to the patient which have received Ibrutinib, it was 67.3%. So Zanubrutinib has shown a better PFS as compared to Ibrutinib. This is the toxicity. So in the toxicity, the atrial fibrillation rate are much less with Zanubrutinib and as compared to Ibrutinib. So as we have also seen that Acalabrutinib is also showing less atrial fibrillation and atrial flutter. Other risk factor like cardiac disorder is also less with the Zanubrutinib as compared to Ibrutinib. And neutropenia is slightly more with Zanubrutinib as compared to Ibrutinib. And this is one more trial which have shown frontline Zanubrutinib in combination with the bendamustine and rituximab. So this is a comparative study. One arm had received Zanubrutinib and other arm had received combination of rituximab and bendamustine. This is the patient which are without 17p deletions. So this is the PFS. So the patient which have received Zanubrutinib, 24 months PFS was much better as compared to the patient which have received BR. So the difference is between 85% to 69%. So now we have many BTK inhibitors. How we can choose those BTK inhibitors? So the patient which have no cardiovascular risk factors, the patient which have no history of myocardial infarction, the patient which have no atrial fibrillation, so we can give any BTK inhibitors. And but our choice is now maybe Acalabrutinib because of less toxicity. But in the patient which have low or intermediate cardiovascular risk factors, or the patient which have permanent or persistent atrial fibrillation, hypertension, or having history of myocardial infarction, then second generation BTK inhibitor, maybe Acalabrutinib or Zanubrutinib should be preferred. And the patient which have very high risk of cardiovascular risk factors, in those patients, BTK inhibitor should not be given. So there is, in many trials has shown that the efficacy of BTK inhibitor with or without anti-CD20 monoclonal antibody is almost similar. So giving BTK inhibitor with combination of monoclonal antibody or without antibody, still this question was not answered. But in one trial, Elevate TN trial, they have used Acalabrutinib in combination with obinutuzumab. This trial has shown that the CR rate are slightly better in the patient which have TP53 mutation or the patient which have unmutated IGVHV. But still, this question was not solved. So we can give only single agent BTK inhibitors without any combination of monoclonal antibodies. So various phase 3 trial has shown that the BTK inhibitor once started, it should continue as compared to the other treatment like chemotherapy or venetoclax. So after relapse, so what are the other options? The patient which have previously received BTK inhibitor or previously received venetoclax based treatment, other options may be non-covalent based BTK inhibitor or PI3 inhibitors or the chemotherapy in patient which doesn't have high risk factors like TP53 deletion. This is the algorithm. So the patient which have previously received chemotherapy, we can still use ibrutinib, venetoclax or acalabrutinib. The patient which have received BTK inhibitors and those patients which are unfit, we have to use venetoclax in combination with rituximab or obinutuzumab. Other option may be PI3 inhibitors. And in fit patients, initial treatment may be venetoclax with rituximab, but if patient has relapsed refractory CLL, other option may be CAR T cell therapy or maybe allogenic stem cell transplant. The patient which have received prior BCL2 inhibitors, in unfit patient, we can give ibrutinib, acalabrutinib. In fit patients and the patient which are very young with having many high risk factors, the CAR T cell therapy and allogenic transplant may be considered. The main problem with BTK inhibitors is the resistance. So resistance of BTK inhibitors mainly occur because of BTK mutants. The most common mutant may be BTK C481 and other it may be because of PLCG2 mutant. So these two are causing around 80% of the patient which have BTK inhibitors, BTK mutations. So this is the BTK mutation that is C81. So this mutation patients, they have resistance to Acalabrutinib, they are resistant to Ibrutinib and also Zanubrutinib. So with this mutation, the first generation and second generation BTK inhibitors are not working. So what is the answer for those patients? For those patients, the other option is non-covalent BTK inhibitors. The BTK inhibitor first generation and second generation, they are binding with this C481 area, but the patient which are receiving non-covalent BTK inhibitors, so like Pirtobrutinib, so this does not require C481 to bind. So those patients have good response with non-covalent BTK inhibitor which have this mutation. And according to selectivity of the BTK inhibitions, Ibrutinib is mainly non-selective type, but these non-covalent BTK inhibitors, they are more selective. So because of more selectivity, they are causing less side effects, mainly less atrial fibrillation and hemorrhage. So depending upon the initial treatment and the resistance, so the patient which are resistant to initial BTK inhibitors, the option is only non-covalent BTK inhibitors. And the patient which are intolerant, in intolerant patient, we can change to other BTK inhibitor, like the patient which have intolerance to Ibrutinib, we can still give Acalabrutinib. So in summary, the evidence confirmed that efficacy of covalent BTK inhibitor as first line option. And so this covalent BTK inhibitor now as a first choice of treatment in almost all patients, the patient with P53 mutation or without mutation, fit patient and unfit patient, both can be taken. And currently there are two main classes of oral small molecules. One is the BTK inhibitor, other option is the BCL2 inhibitors, that is venetoclax. The venetoclax based treatment may be a time limited treatment. So venetoclax can be used in combination with rituximab or obinutuzumab. So the patient which require only fixed duration treatment, we can give chemotherapy based treatment or venetoclax with rituximab combination. And the patient which want only oral treatment and the continuous treatment, then we can give BTK based treatment. And the patient which are having resistance to BTK inhibitors, the other option is non-covalent BTK inhibitors. So with this, I end, and I will happy to have any questions. Thank you.
Thank you, Dr. Jeevan. That was an excellent talk, and you very well navigated your sessions right from the beginning, historical aspects when BTK inhibitors were not available and how the patients were treated. And now we have the privileges of having a lot of glutathione kinase inhibitors, following by the non-covalent glutathione kinase inhibitors, and then the other drugs which are there may not be there in India in the available, but yes, someday they will also be there for the patients. So excellent session, and as the studies have said, all the studies are now comparing the newer glutathione kinase inhibitors with ibrutinib, which obviously has to have some advantages. Of course, the efficacy wise, Acalabrutinib seems to be similar to that of ibrutinib, but yes, as you rightly mentioned, the selectivity matters, and that's the place where the side effects like hemorrhage and arrhythmias come into the role. So just one question from my side, Jeevan sir, to you. Now, since we are expecting these side effects, so how frequently are the patients monitored for these side effects when they are put onto the older glutathione kinase inhibitors?
Initially when we are starting BTK inhibitor, generally we are evaluating the cardiovascular risk factors, mainly atrial fibrillation or any previous history of having ischemic heart disease or hypertension. So initially we have to monitor it every week, and once patient has settled and not having any major side effects, then we can monitor every month. And slowly after like 4 or 5 months, if there is no major side effects, we can monitor every 2 monthly or 3 monthly.
Okay. And regarding the time when one needs to think about other glutathione kinase inhibitors, for example, as you said, if one patient is resistant to the initial inhibitors, so how long one has to wait and then decide that the patient is in resistance to ibrutinib or another glutathione kinase inhibitors to shift the patient onto another. So how long one has to wait?
So the patient which are taking BTK inhibitor, they are taking continuous treatment. So if on continuous treatment, still patient is developing some cytopenia, that is not because of treatment. So we have to do a bone marrow to evaluate whether it is because of CLL or because of the treatment-induced myelosuppression, or if patient have some lymphadenopathy. So we have to confirm. But unfortunately, till date, the mutation analysis for BTK inhibitor is not available. So we are doing only clinically. If patient has relapsed CLL, then we have to change the treatment. The option only which is available for those patients is venetoclax-based treatment. The non-covalent BTK inhibitor is still not available.
Yeah, actually. So I would request if there are any other questions for Dr. Jeevan, or we can take the questions later on. So thank you, Dr. Jeevan, for that excellent talk. I now
Thank you.
request Dr. Demalya sir to start his talk about BKT inhibitors in and once he's done, and then we can have the other speaker. So over to you, sir. You can start sharing your screen.
I don't have laptop right now. So please, can anyone upload my slides? I think Sudeep has my slides.
Yeah. So he's there. Dr. Sudeep.
Hello, sir.
Can you upload my slides? I don't have right now. I don't have a laptop with me. Actually, I have laptop. I don't have. My internet connection is poor through my mobile. So as long as he takes time to,
you can send the slide to Dr. Sanjay. Dr. Sanjay will do that same.
I don't have his mail.
No, I'm not saying you, sir. I'm saying Sudeep.
Okay.
Sudeep.
Okay.
Sudeep, please forward it to Dr. Sanjay immediately. So can we go to other
Yeah,
presentation if it is taking time?
Yeah, that is also okay.
Hai na?
Yeah, no problem.
Dr. Sanjay, you can take the other presentation.
Is Dr. Priyanka there? Dr. Priyanka, are you there?
Yeah, is my video not?
Just
Yeah. You're there. Ma'am, can you start your talk on the real world evidence, and then later on we can invite Dr. Devman. This presentation is a bit.
Okay.
Yeah.
Thank you, Samarth Oncology, and thank you, Dr. Jeevan, for briefing us and having us through that BTK inhibitors in CLL. So this also is a real world data, and I have been focusing more on CLL and tried to put up what has been our experience in my center. Just a minute, let me share the slide. Are my slides visible?
Yes. You can make it full screen.
Okay. Just a minute. Yeah, so this is regarding the real world data on Acalabrutinib. I have tried to focus on CLL.
It's still full screen is not there. It's still in the.
But from my end, I have made it full screen.
Yeah.
Just a minute. Now is it in the full screen mode?
No, not yet. Not yet. What you can do is again start resharing. You can unshare and reshare. That may work.
Just a minute. Now is it visible as a
The
full
slides, the slides are visible, but the full screen is not.
No, from my end it is in the full screen mode, but it is not. Let us continue with it.
Okay, fine. Let us know.
Because I hardly will be having some of the slides which are very small to not be visible to everyone.
Yes.
So, yeah. So these are some of the literature which we went through. Characteristics of the mantle cell lymphoma 2019. This is the publication, and CLL patients treated with acalabrutinib in the real world setting in US. So what we just heard from Dr. Jeevan, it is like the Bruton kinase inhibitors after they have come up. It has almost changed the management of these indolent lymphomas in a very beautiful way, especially for the elderly patients who are frail, who do not want to come to the hospital, as well as there are not much caretakers who will be taking care of the patient coming to the hospital, getting admitted for a day or two for the chemotherapy. So possibly this is a game changer for that group of patients. But then there is a challenge for us in India, as we find many of the patients with these lymphomas being presented by a decade earlier. So in those patients, whether to continue with a lifelong therapy or to provide them with a definite therapy, that remains a question, even in spite of the fact that IGHV mutated as well, unmutated, as well as the TP53, where we have to go for a BTK inhibitor or a venetoclax-based regimen. So this was the characteristics. The aim was a descriptive analysis of the use of acalabrutinib in the real world setting. And patient profile and endpoints, they have mentioned 264 mantle cell lymphoma and 204 CLL patients who were treated with this acalabrutinib were identified in the study. So they found that 60% of the MCL as well as CLL acalabrutinib treated patients were defined as high risk of atrial fibrillation. In terms of prior BTK inhibitor treatment, approximately 40% of the MCL and 65% of the CLL patients had prior ibrutinib use. So because as we just saw, ibrutinib was the first drug which was approved. So many of these patients were already exposed to the first line BTK inhibitor. So the patients who were more prior ibrutinib users were defined as high risk atrial fibrillation status at the time of acalabrutinib start than patients without prior ibrutinib. That means,
Madam, sorry to interrupt, but the slides are also not moving.
oh my God. So just a minute, let me put it in the slideshow mode in my,
Yes.
So this is fine?
Yeah, now it is, yes.
And
Yes.
these are moving?
Yes.
Right. So, right. So prior ibrutinib users had a higher frequency of several comorbidities like hypertension, fatigue, and asthenia. So this itself shows that patients, when we had only one option of ibrutinib as a molecule, definitely patients who were even having some amount of cardiac comorbidities, they were also exposed to the drug. And therefore, when these patients were later on shifted to the second generation, that is acalabrutinib, still they had a risk of having a heart disease or a cardiac illness. So they concluded with the relatively recent approval, this was the first analysis of acalabrutinib used in clinical practice and description of characteristics of the MCL and the CLL patients being treated with this medication in the real world. So before initiating acalabrutinib, approximately 1/3 of the MCL patients and 2/3 of the CLL patients had already received ibrutinib, and there were some reasons for discontinuing ibrutinib which were not explored in this analysis. So overall, the comorbidity score was similar between the groups with or without prior BTK exposure, and BTK inhibitor naive patients had a slightly lower frequency of having higher AFib status than those who were initiated at the acalabrutinib drug. So that is what I mentioned why it was so. So next is another paper which compared acalabrutinib and ibrutinib in the real world, and it was a study of 2,509 patients with CLL. So this was again a real world analysis of acalabrutinib versus ibrutinib to compare patients who were non-trial. This is also important because all of us, we have been practicing these malignancies. You see, when the patients are taken up in a trial, definitely they are the ones who have a lot of exclusion criteria. But then when in the real world, we have to administer this molecule even in the patients who have some amount of comorbidities or who do not fit into that exclusion criteria. So the results were analyzed from January 2018 through February 2021. And this was the number of the patients. 89 to 90% of the patients received ibrutinib and 14% received acalabrutinib across all lines of therapy. So what they found was, in the unweighted analysis of all patients, there was no significant difference in the time to discontinuation between the acalabrutinib and the ibrutinib cohort. You can see very well they are merging here in this graph of the Kaplan-Meier graph. So after the average treatment effect on the treatment weighting, the overall time to discontinuation for acalabrutinib was significantly longer compared to ibrutinib. Here you can see a slight separation between these two arms. And this is relatively because, as already discussed, acalabrutinib has relatively off-target side effects are less as compared to ibrutinib, which has a much more number of inhibitions apart from the Bruton kinase. So what were the reasons for discontinuation in patients with CLL? Some of the, in the acalabrutinib as well as in the ibrutinib arm, you can see 12.7% versus 19% in the ibrutinib arm, 4.2% of arthralgia as compared to 2.1% in the in the ibrutinib arm. So almost most of the cytopenias or the cardiac toxicities, they were higher in the ibrutinib arm as compared to the acalabrutinib arm already discussed. So the discontinuation rate across all lines of therapy at 12 months was 22% for the weighted acalabrutinib versus 31%, which is higher as discussed in the ibrutinib arm. Yeah. So this study, it is the largest available analysis, 2,500 patients they analyzed, comparing the two BTKIs to date, and suggest lower rate of discontinuation and a prolonged time to discontinuation for patients on ACAL as compared to ibrutinib, both in the frontline as well as in the relapse refractory settings. And this relapse refractory is not based upon patients who are relapse refractory to ibrutinib and then they have been changed to acalabrutinib. It is mostly the ones who were intolerant to ibrutinib has been changed to acalabrutinib. So while randomized clinical trial data have compared patients treated with ACAL and ibru in the relapse refractory setting, these data provide valuable insight into how these agents compare in the frontline setting, which was not tested in the ELEVATE relapse refractory setting. However, we still have some data with the ELEVATE TN or the treatment naive patients as well, which have now come up. The outcomes in clinical practice across treatment lines also have been studied outside the trial setting. So this was what the trial mentioned, that whatever in the ELEVATE RR trial, it was also the same in the real world scenario. So the next was real world effectiveness and safety outcome of acalabrutinib treatment by line of therapy in patients with CLL or SLL. So lines of therapy means the patient already has received some amount of chemotherapy earlier and then they have had a relapse had a relapse. So the aim of the study was to describe time to next treatment, overall survival, and the bleeding events in the patients receiving the first line and second line therapy for CLL and the SLL in the real world. So a total of 530 patients were identified and included in the analysis. 63% received ACAL in the first line and 37% received it in the second line. So at baseline, 18%, 75% and 16% of the patients had atrial fibrillation or flutter, hypertension and bleeding episodes respectively. So here you can see that the things which this drug predisposes to, these patients already had this at the baseline. With a median follow-up of 9 months in the first line cohort and 12.4 months in the second line cohort, the median time to next therapy and the OS was not reached in either cohort. That means even in the patients, if they had these baseline abnormalities, still these patients had a response to therapy as well as they were able to continue the therapy. So the results at 18 months, the proportion of patients remaining on treatment was 82% in the first line cohort and 78% in the second line cohort. So as just we discussed, Dr. Jeevan also mentioned that when a patient is being prescribed for a BTK inhibitor, we look into the cardiac ailments, we do underlying, the baseline PT as well as the APTT to look into whatever is his baseline bleeding tendency. So you see, in spite of the fact that these patients had, still 82% of the patients were on the therapy, which is quite a significant number of percentage of the patient. So of the patients that progressed, the median time to next treatment was 4 months in the first line cohort and 4.2 months in the second line cohort. So the 18 months overall survival rate was 90 and 85% for both the first as well as the second line cohorts respectively. And here you can see the graphs which are very well overlapping with one another, and the time to next treatment has not reached for both the arms. So after initiation of Acalabrutinib treatment, incident rates of AF, hypertension, bleeding events were very much less. You can see 2.7%, 9%, and 2.7% in the first line, and 7.4, 2.4, and 3.5, 3% in the second line therapy. So the inference is that even with this, the safety of the drug remains there, and the patient can be, the observed incidence rates of cardiovascular and bleeding events were not consistent with those observed in the published Acalabrutinib trials. So this is again a real world data where they have shown that in spite of these comorbidities, when the drugs are being given, still they are able to continue the drug. The time to next treatment is also prolonged because of the tolerability and less amount of the side effects. So definitely the amount of the publications they have, the trials they have so much emphasized on this cardiovascular and bleeding events. In the real world, if you continue giving them, might be the incidence of these side effects will be much lower than what has been published in the trials. So this is possibly the last publication we'll be discussing about toxicities and outcomes of Acal treated patients with CLL, a retrospective, again a real world experience. So this was carried out in 9 US cancer centers. And again, the most common reasons for choosing Acal were prior intolerance to other agents, mostly the prior ibrutinib use. And this is the reason why it was 98% of the patients who were intolerant were started on this drug Acalabrutinib. So in this group of largely ibrutinib intolerant patients, the overall Acal discontinuation rate was lower than prior reports from clinical trials, although with relatively short follow-up. However, the discontinuation rate due to adverse events appears to be similar to the clinical trial data in an ibrutinib intolerant patient population. So conclusion was that patients who are ibrutinib intolerant can safely be given Acalabrutinib. And in our real world, whatever is what we have faced, I have tried to summarize this our experience of CLL. So this was a retrospective study. Actually, very recently, we just tried to analyze our data. From 2018 to 2023, we took the cases were the newly diagnosed as well as the relapsed refractory cases of CLL, treated either with bendamustine rituximab or with the Bruton kinase inhibitor. And to mention, both the BTKs were used, Acalabrutinib in some and ibrutinib in some. And since ibrutinib is now almost off the market and it is being difficult to procure ibrutinib, most of the patients have been shifted from ibrutinib to Acalabrutinib, not because of intolerance, but because of the unavailability of the drug in the market. So inclusion criteria, all cases with CLL with an indication for treatment were treated, and excluded exclusion criteria were the ones with Richter's transformation, non-CLL CLPDs, and CLL cases with modalities other than the BR or the Bruton kinase inhibitor. So, treatment groups, I said there were 2 arms. So results when we saw, there were total of 57 cases in this time period of 2018 till 2023. There were indications for therapy in 26% of the cases. Benda-rituximab was given in 15 and Bruton kinase inhibitors were given in 11% of the 11 cases. Response assessment was done. We have slide on that. So the percentage who received BR was 57% and Bruton kinase inhibitor was 42%. Age distribution, we know it is a disease of the elderly. So most of the patients fell in the group of 61 to 70. The male is to female ratio, male were 8 and female were 3. So almost it was the male is to female ratio was 4.4:1 in the BR group and 2.6:1 in the BTK group. So follow-up and median follow-up duration was 34 months. Follow-up duration ranged from 6 months to 68 months. Mean age of patients who received the BR was 60 and the proton kinase inhibitors were 65 years. So the response rate you can find here, complete response. This has been taken as per the chemotherapy response criteria. BR total number was 8 and this was 53% approximately. PR partial response in 33% of the patients and stable disease it was 13%. So as we know that in proton kinase inhibitors, there is always a lymphocytosis. So partial response was seen in 72% of the cases and CR in approximately 20% of the cases with 10% having stable disease. So this is again important to look into how the mortality was among this group. So among the BR group or bendamustine rituximab, the survivors are 67%, 33% patients have died. Some of them during the first or the second administration of the cycle, and few of them have died irrespective of not because of the CLL but because of other comorbidities. And here you can see proton kinase inhibitor, a very safe drug. Approximately 70 to 75% of the patients are survivors, and only there is 3 mortality. So overall mortality of the study in our study was 30% approximately. No significant difference in mortality between both the groups. Most common cause of death was pneumonia and some other causes which was not related to the CLL. One of the patient had dilated cardiomyopathy and he had received benda-rituximab, and one of the patient he died of DIC post sepsis and septic shock. So median PFS approximately 52 months in patients with BR, and it was 43 months because it is a shorter follow-up for the patients on proton kinase inhibitor. Overall survival, BR is approximately 66%, and just we had seen the data which was shown by Dr. Jeevan. There also the BR group had approximately 60 to 65% of OS, and the proton kinase inhibitor, it was 72%. So it is a better one, and we still have time to follow up for these patients who are on proton kinase inhibitor because they have started late on this drug or on this therapy. So aberrations, if you look into our patients, they had most frequently, it was the deletion 13q as reported in literature, followed by trisomy 12, and then deletion P in 2% of the patients. And at that point of time, the patient had received BR because ibrutinib was not available with us. And IGHV mutation, you can see 46% mutated in the BR, and it is also 18% approximately in the proton kinase inhibitor. So this study actually, this is again a real world, whatever we have faced or we have treated our patients with the 2 arms, and it was almost all a comparable outcome between the BTK inhibitor as well as the BR. Overall survival, we just discussed, it is 66% in the BR as opposed to 72% in the BTK inhibitor arm. So fatigue, hypertension, weight gain, easy bruising were some of the adverse events which were noted with the ibrutinib, but this has not actually caused the discontinuation of the drug. But now with the availability of acalabrutinib, obviously our prescription for acal has much more gained momentum as opposed to the ibrutinib. However, I feel as per my experience, the ibrutinib as well as the acalabrutinib, both of the drugs are well tolerable, and only one of our patients of ibrutinib had to discontinue the drug because of hypertension, which was not controlled, but not because of the AF. The safety profile, acalabrutinib is the best tolerated drug among all the regimens. So that was what we concluded. And just I have few more slides on cold agglutinin. We recently had a patient who was diagnosed to have a cold agglutinin disease with hypertension and a history of STMI. So this patient was 67-year-old male, presented with weakness, and he was referred to us from actually the cardiology department because he had coronary artery disease, had been operated for hernia in 2017. And you can see there was pallor and a lot of icterus. The patient did not have a palpable spleen. Bone marrow, it was hypercellular and showed some amount of lymphocytosis. NGS was sent for MDS. We never knew that he had that at that point of time that the patient will be having an autoimmune hemolytic anemia because other features were not very suggestive. But just as a part of the workup and DCT was done, DCT was positive, and then a cold agglutinin test was done, which was positive again in a high titer of more than 1:512. SPEP was negative because there was some amount of lymphocytosis. We thought that whether it was associated with lymphoproliferative disorder. 2D echo, almost the ejection fraction had become normalized by then. Cardiology consultation was done for the hypertension and the STMI. 2D echo almost normal. Patient was started on EcoSprin. So, looking into that, first the patient actually was started on prednisolone before the patient was referred to us. But then when we got this cold agglutinin disease titer and everything, and there was no improvement in prednisolone, we started with the bendamustine and rituximab protocol, which was modified because of the hyperbilirubinemia. Actually, the amount of low hemoglobin or anemia, it was not able to correlate with the amount of hyperbilirubinemia the patient had. So initially he was given 2 weekly rituximab, only waiting for the improvement of the bilirubin, and later on bendamustine was added after the bilirubin fell down. Completed 6 cycles of BR, but response was noted in the response noted in anemia was not very persistent. So there was icterus as well as some amount of anemia requiring multiple hospital admissions. So we went back to the literature and to look into how this cold AIHA could be best treated, and this was from the ABS education book, where we found that ibrutinib, when given at a dose same as that of CLL, the overall response rate was approximately 100%. And we started this patient on ibrutinib, and cardiology clearance was again taken because we knew that with an underlying cardiac illness, how this ibrutinib is going to be, tolerability, how the tolerability will be for this patient. So he was started on 420 mg, and hemoglobin response was maintained. He has taken 7 cycles of ibrutinib till now, tolerating well, icterus resolved, and maintaining a hemoglobin of approximately, you can see how it has increased, and it has maximum gone up to 11, and he has been maintaining it throughout. Bilirubin again has fallen down. Initially, it was much higher. This was in 2022. When he presented to us, the bilirubin was approximately 8 milligram per DL. So that is how I wanted to mention that apart from CLL and MCL, even in patients who are refractory, in cases of the cold agglutinin disease, we can use Bruton kinase inhibitor as one of the salvage therapies. So thank you. And if in case there are any questions, or we can take it up.
There are two questions for Dr. Jeevan Garg, and if Dr. Jeevan sir can take the question, or Dr. Priyanka can. One is, I can read that question, that acalabrutinib dose titration is required in weekly dialysis patient. And one more question is, any biomarker need to monitor regularly during the acalabrutinib treatment? If Dr. Jeevan can answer, it's good, or Dr. Priyanka can help us out.
Yeah, for the biomarker monitoring as such, no biomarker is required, but you have to just do the patient's history for, any bleeding, and we have to monitor the CBC for cytopenia. Biomarker monitoring as such, there is no specific biomarker which we have to monitor. We have to look for the toxicity of the medicine, and in the long term, we have to look that the disease is responding or patient has relapse. And regarding the dialysis, so I am not sure about the acalabrutinib dose titration in dialysis patient. Dr. Priyanka, do you have any experience?
No, possibly there is no literature regarding supporting the fact that in these patients, how you have to continue this drug. There is not much evidence. Even if you look into the product insert also, they do not provide any dose modification. No pharmacokinetics have been done for this drug in the patients who are on
Yes,
dialysis.
as long as I can remember, there is no such thing.
Yeah.
Only thing is that some CYP inhibitor like fluconazole, posaconazoles, for these patients, there may be some dose modifications. For CKD, they have not made.
Very much for the insight. Now, Konark, are you ready with the slide of Dr. Dev Malya?
Yes, sir. Yes, sir. I am ready with that. I'll share the slides.
Please share. Dr. Sanjay, you can give the brief introduction of Dr. Dev Malya if required.
Yeah. Actually, I've introduced all of the speakers, but still, it's my pleasure again to welcome Dr. Dev Malia. And Dr. Dev Malia, over to you for your talk. Later on, we can
Yeah.
take up more on that.
Thank you, Samarth, for this timely program of BTK inhibitors in other, different types of lymphomas. So my topic is in mantle cell lymphoma patients, the role of BTK inhibitors. So I'll skip some slides because it will not be easy to complete all the slides. So I'll just go through the salient points that BTK inhibitors are very good weapons for treating the mantle cell lymphoma patients, especially in the elderly age group or the patients who are not that fit, because previously we used to take mantle cell lymphoma as a very aggressive therapy with RDAP, autologous transplant, and other toxic chemotherapies. But nowadays, because of these BTK inhibitors and venetoclax, the treatments becoming easier. Next. So next, I'm not skipping these slides because everyone in amongst us mostly know about these things. So the cause and risk factors also I'm not going in details. Next. So everybody knows that for diagnosis, your PET scan and a good morphology immunohistochemistry is essential for the diagnosis. Next. So the mantle cell has a typical tendency to involve the other places, other sites in the body apart from bone marrow, that is GI tract, at times kidneys, and many patients of mantle cell lymphoma has some typical glomerulonephritis like things, which is beyond of our discussions today. Next. So I'm not going in details of like this. Next. So newly diagnosed mantle cell lymphoma, the treatment is decided by the patient's profile, age, fitness, and other comorbidities. So first cycle patients, fit patients, conventionally we use bendamustine rituximab or R-CHOP or intercalated R-CHOP and RDAP, like that. Those protocols followed by autologous transplant if it is necessary. And for unfit older patients, rituximab, chlorambucil, rituximab, lenalidomide, or cladribine, these are the old group. And for relapsed refractory disease, the protocol was ibrutinib with rituximab, rituximab with acalabrutinib or venetoclax, like that. Next. Since 2022, the many things have changed. There are many data analysis, namely Flaritron database analysis, SHINE trial. So these are the trials which held triangle trials. So these trials, have changed our pathway of thinking. Recently, I was in MD Anderson. There I have seen that many patients of mantle cell lymphoma are getting upfront acalabrutinib, venetoclax, and obinutuzumab or rituximab trial or therapy. And these patients are doing very well on the long-term basis. Patients are being devoid of toxicity of the so-called chemotherapy. So this immunotherapy with rituximab, venetoclax, and acalabrutinib is a very good treatment protocol cocktail for these type of patients. Next. Now the NCCN guidelines in 2023, they have said that candidate for autologous transplant, for those only consider the aggressive regimens, and those patients who are not a candidate for eligible transplant, for these patients this BTK inhibitor is a boon. And especially the patient, those patients are usually less elderly age group patients, and the toxic protocols which can be. Next. Now, is there a role of BTK inhibitor based treatment in previously untreated MCL? So obviously this should be the question of the age. So currently FDA approved for patients of MCL who have received at least one line of therapy. For the patients of ibrutinib, acalabrutinib, and zanubrutinib, these BTK inhibitors are irreversible covalent BTK inhibitors, and they are undergoing phase 3 trials as parts of different combination regimens. Next. Now these are the SHINE trial was first line ibrutinib and bendamustine and rituximab, followed by rituximab maintenance in older patients of MCL. So ibrutinib 560 mg was the dose for these patients. Next. Now the results were treatment with bendamustine plus rituximab maintenance therapy. Sorry. So, hello, am I audible? Yeah, sorry. So for this age group of for this group of patients, the conclusion was there is a good prolonged survival with these protocols. Next. Now another was triangle study. So triangle study, they showed there are some different arms with R-CHOP, with RDAP intercalated or R-CHOP, RDAP intercalated, and with ibrutinib RDAP. So addition of ibrutinib, there was a better response, overall progressive-free survivals. Next. Next. So the addition of ibrutinib during the addition of ibrutinib during the induction as maintenance showed stronger efficacy with acceptable toxicity, and it was demonstrated that current standard high dose regimen is not superior to the new ibrutinib content regimen without ASCT. But these current results already support the use of ibrutinib in the first line treatment of younger MCL patients. So this was the matter of debate that whether ibrutinib should be used in the first line in young patients. And from this trial, we can hypothesize that yes, these BTK inhibitors can easily be given in the younger patients also. Next. And also there is another phase 2 trial of acalabrutinib plus lenalidomide plus rituximab. Next. So this frontline MCL, there is a lots of new data of MCL in last 1 year. So for younger patients, the triangle study that suggests that we can add the BTK inhibitors and subtract ASCT, which is a path breaking point, and not published that NCCN guidance suggests that we can substitute acalabrutinib or zanubrutinib, because ibrutinib is many places like US in many centers they are not using ibrutinib because of the side effects, and zanubrutinib is many places is widely available, but it is not in India. Next. Now for the relapsed refractory MCL, personally I think the decision is very easy, because as the disease has relapsed, so you can use many drugs like venetoclax and other newcomer BTK inhibitors like pirtobrutinib, and obviously the CAR T cell therapy and bispecific therapy, which have immense efficacy in some relapsed refractory patients where there is no hope left. So these CAR T cells and bispecific monoclonal antibodies have opened a new horizon for these type of patients. Next. Now the factors considered when consider treatment with covalent BTK inhibitor with relapsed refractory MCL. So we don't have this luxury to compare between this non-covalent or covalent or reversible or irreversible BTK inhibitor. So the main factors for us, the other comorbidities and cost, availability of the drug, which is very important, and TP53 mutation status. Next. So there are trial results and many things which that led to the approval of acalabrutinib, ibrutinib, and zanubrutinib in relapsed refractory MCL, because they have very good data in relapsed refractory patients. This only has helped them to think of this BTK inhibitor in the primary of the frontline patients. Next. Next, so I'm not going in details of these slides because it will be very boring to read all these slides. So these are the guidelines for these BTK inhibitors in mantle cell lymphoma, NCCN guidelines. So they have overall, these studies have advocated the use of these BTK inhibitors in all types of mantle cell lymphoma patients. Next. Now, this development of resistance to these BTK inhibitors is another point of concern. So there are another studies that for those who are patients are resistant to BTK inhibitors.
Hello, doctor, are you there?
Dr. Devmalia got muted. Sir, can you unmute? Still muted.
Anilji, can you unmute him?
Hello,
Yeah,
hello,
yeah,
hello. There's some problem. Yeah. Hello, now am I audible?
Yes, yes, yes.
Yeah, just a second. So next. Yeah, so there is another trials or updates for this ibrutinib with venetoclax in relapsed refractory multiple mantle cell lymphoma. So the median overall survival was in this patient was quite good, that is 29 months. So it raises the prospect of limited duration targeted therapy in the relapsed refractory mantle cell lymphoma, and we know these treatments are not curable. So overall, the patient will ultimately relapse, but it will prolong some progression-free survivals for some period of time overall. Next. Now the emerging roles of reversible non-covalent BTK inhibitors in MCL. We don't have any personal idea for these things, but we just have some theoretical ideas for these type of patients. Next. So the overall treatment recommendations for this group of patients are. This is a very nice slide, that aggressive chemotherapy for young patients, then consolidation, and for those patients who prefer the second line therapy, and for these patients you prefer the Acalabrutinib, Zanubrutinib along with one rituximab, and you can add venetoclax, and those patients who have failed all those things, for this group of patients you can go for this CAR T cell therapy or the BiTE cell therapy. And another option is there, that is pirtobrutinib. I don't have any idea of this pirtobrutinib because it is only theory for us, and this is a non-covalent BTK inhibitor. Next. So these non-covalent BTK reversible inhibitors, they have more efficacy in the resistant BTK inhibitor patients. So we don't know about the long-term outcome, but still we can. This is a good hope for those patients who are not affordable for the other drugs. But I think this will be a very costly drug. Next. So I'm not going details of this molecular structure. Next. So this will be also a molecular one, so I'm not going in details. Next. Now this is a Bruin trial which can tell that the pirtobrutinib in previously treated patients. So there is the dose is in the phase 1 trial is 25 to 300, whereas in other phase 2 trials it is 200 mg per day, and it's a 28-day cycle. So it is almost like the dose, the duration is like daily dosing. Next. So obviously the patients who have prior treatment, there's a good efficacy as per this diagram. So next. So this is, I'm not going through. Next. Now the progression-free survival by this group was 7.4 months, and duration of response was 21 years. And the overall survival and 12 to 8 months survival rate was 67% and 59%. So in relapsed refractory group patients, so this is quite impressive. It is not bad at all. Next. So it is a first-in-class non-covalent reversible BTK inhibitor, and the first inhibitor of any kind which can have durable efficacy even after prior other BTK agent therapy. Next. Now the overcoming barriers of the BTK inhibitors, safety of BTK inhibitors. So there are specific side effects of BTK inhibitors in all type of patients, specifically like ibrutinib, the bleeding effects, arrhythmia effects. I think everybody has covered this. And the specific for acalabrutinib is the headache, which can be reduced by some acetaminophen and caffeine. Next. So this is another one. There is specific side effects for this is a cardiac disorders and atrial fibrillation, but this is less in case of pirobrutinib. So it is a quite promising drug, but I don't know whether it will be on long-term basis that helpful. Next, or when it will be available in India. So in 2023, the FDA granted accelerated approval to pirobrutinib for relapsed refractory patients with more than 2 lines of therapy. Next. Now already this thing I have discussed, the second line and subsequent therapy. There are some other drugs which can be used in this scenario was lenalidomide. But what I have seen there in that is this venetoclax is very promising in some cases of mantle cell lymphoma and definitely in cases of CLL. Next. And for these new drugs, even this janubrutinib is not available in India, so we are quite far away from this pirobrutinib. Next. Next. Yeah, I think it is over. Next. Okay, next. Next. So we have covered everything. So I think we have covered the other slides are not that much necessary for our discussions. Thank you.
So I think, thank you, Dr. Devmalya. You covered the part very specifically because after the two speakers delivering their talk, more or less, it was more of a repetition that you skipped it.
Yeah, exactly.
However, that was a wonderful session wherein most of the trials on mantle cell lymphoma you could cover. And of course, the previous speaker, Dr. Priyanka ma'am, the data which she presented from the retrospective or the real world data was very much enlightening. Because the clinical trials are always done in the close control environment. However, the real world data is actually the data which emerges, which gives a lot of insights on specifically the side effect profile, wherein Madam has very wonderfully summarized about the side effects that were not much of a difference. And of course, the efficacy was also more or less there was similar efficacy with the drugs compound. So as we go on, the question and answers we can take up later on because we are already running behind schedule. Now I would invite Dr. Kusmita ma'am to start her case presentation. Following that, we can take up the questions. Dr. Kusmita, are you there?
Yes, I am here. I
Yeah,
have given the
yeah. Should I
slides.
start
Kindly,
sharing your slides? Okay, I'll just
okay,
start sharing it. Yeah.
Okay. Welcome everyone and thank you. I am Dr. Kushumita Roy, Assistant Professor of IHTM, Institute of Hematology and Transfusion Medicine in Medical College, Kolkata. I would like to start out by presenting a simple case for the beginners. Next. A 67 years old man pursued laboratory testing as a part of health screening offered by his physician and was advised to visit hematologist based on the initial test result. He has not experienced any acute symptoms like fever, chills, rigors, nor weight loss, but only complaint is that he is feeling more tired for the last few months. The patient did not have any personal or family history of cancer and is not currently taking any medications. Physical examination is unremarkable and there is no organomegaly or palpable lymphadenopathy on physical examination. Next slide. The investigation which I got in the first visit was hemoglobin 11.7 gram percent, total count around 21,000, of which 70% is lymphocyte and platelet is adequate. And other biochemical investigations like LFT, urea creatinine, fasting as blood sugars, ECG, echo were unremarkable. So the patient presented with lymphocytosis, and the differential diagnosis for lymphocytosis is quite broad and would include CLPD as well as reactive causes like viral infections and bacterial. Cytosis. As a clinical for lymphocytosis, CLPD should be considered strongly. So I advise to come after 1 month with a repeat CBC and with peripheral smear, CT, neck, thorax, abdomen, pelvis, immunophenotype from peripheral blood for CLPD panel, FISH for the following chromosomal abnormality, and molecular study for T53 and IGHV mutation. And the party was also counseled about the disease outcome and the types of therapies and their efficacy and toxicities. And he was asked to take the vaccines, Influvac and pneumococcal vaccines. Next, in the next visit, the peripheral smear report came like that. There is morphologically homogeneous lymphocytes with clumped chromatin and smooth cells. Again, this patient after 1 month was still asymptomatic, no fresh issues, and having no organomegalies or lymphadenopathy. But his total count raised to 45,000 and 80% of which are lymphocytes. CT abdomen showed multiple intra-abdominal lymphadenopathy, and immunophenotype was that of CLL, as they shows positivity of CD523 along with CD19, 20, 79B, and which confirms that is CLL. Now, by definition, if there is more than 5,000 monoclonal B cell lymphocyte in peripheral blood, it is chronic lymphocytic leukemia. If the count of monoclonal B cell lymphocyte is less than 5,000, along with lymphadenopathy or external involvement, it is called as small lymphocytic lymphoma. Though both the clinical features and the treatment modalities for this CLL and SLL are same. Now, if the patient neither have lymphadenopathy or external involvement, and the count of clonal B cell lymphocyte is still less than 5,000, it is called as monoclonal B lymphocytosis. So our patient is having chronic lymphocytic leukemia with rise stage 0 and BNET A with unfavorable prognostic marker T53 mutation. Now patient was started with Acalabrutinib, and he was on Acalabrutinib for last 1 year without any disease progression and much adverse reaction. Next. Now to conclude or rather to discuss, CLL is a characteristically by accumulation of immunologically dysfunctional mature B lymphocyte with typical immunophenotype including CD5, 23, and that of B cells. It is one of the most common type of leukemia in US, and most of the patient does not require any therapy at the time of diagnosis, but may require therapy depending on their clinical presentations and molecular features of the disease. Now, in CLL patient, whom to start therapy? International prognostic scoring system of asymptomatic early stage disease and that of CLL has categorized this CLL patient into 3 risk groups. They include
So, Kusmita, are you there? I think Dr. Kusmita was disconnected.
I think so. Doctor has lost the connection.
Yeah.
Yeah, doctor has lost the connection.
Dr. Sanjay, sir, you can close with your remarks.
Here, I'll just stop sharing the slides. Let us see whether, because she was at the end of the discussion, and very interesting part of what whom to treat and when to treat. So let us see whether she joins again.
Questions for Dr. Bhattacharya? Would you like to answer, Dr. Devmale?
I think they are on mute. Fine, I think that since we were at the end of the discussion, it's a very interesting case of this person who presented, but then, technical glitches are always there in the digital programs. So anyway, we can, any questions if we have for anybody, just whether. So, yeah. Dr. Bhattacharya, sir, are you there?
I think
Okay.
so.
Yeah. Fine.
Dr. Priyanka or Dr. Jeevan can answer these two questions if they can help.
Dr. Jeevan, are you there?
Yeah, I'm here.
Yeah. So, sir, there is a question that patients with MCL with comorbidity, what guidelines are suggested? Shall we start with ibrutinib or acalabrutinib as the first line? That's the question.
So as such, ibrutinib or acalabrutinib should be started as a second line of treatment. And as now availability of ibrutinib is a problem, so majority of patients we are starting with acalabrutinib, and acalabrutinib has less toxicity, less chance of atrial fibrillation, less chance of bleeding. So our preference would be acalabrutinib in majority of these patients.
Okay. And follow up to this question is that can acalabrutinib be continued during chronic diarrhea situation or in patients with liver cirrhosis with MCL? What does the guidelines say?
So as such, that depends upon the amount of diarrhea. The patient initially can be treated with the medicines which can improve the secretory diarrhea. So, but if after giving the treatment for secretory diarrhea, still patient has multiple times loose motions and which are not able to control and patient have electrolyte disturbance, then we have to stop the acalabrutinib. But the chance of having chronic diarrhea is much less as compared to with ibrutinib. But majority of patients, they are able to tolerate, and with the medicines to control secretory diarrhea, majority of patients, they are tolerating acalabrutinib. So we have never faced this problem of chronic diarrhea with acalabrutinib.
And sir, again, what about those patients who have liver cirrhosis with MCL? So does the guideline allow acalabrutinib to be prescribed in these patients?
The problem with this that the majority of the trials, they have not involved the patient which have liver cirrhosis. The data is very less, but still it can be given with the regular monitoring of liver function test. So, but there is no data that in liver cirrhosis we can give acalabrutinib or not give, because in trials they are excluding those patients.
Yeah, yes, that is very much true. Dr. Priyanka, ma'am, are you there? Dr. Priyanka? Okay, fine. So I think that was a wonderful discussion. We started with the proton kinase inhibitors in CLL and then MCL, and then we had a interesting case study as well as a retrospect, the real world data which was presented by Dr. Priyanka. So I thank all of the speakers, right from Dr. Jeevan, Dr. Priyanka, Dr. Kusumita, who is now not seen, Dr. Dev Malya, who could find some time and have this scientific insights discussed on this platform that we always have from the House of Samarth. And I'm very much sure that this discussion, this presentation would have helped a lot of delegates who had joined us with us for this very exciting sessions today. So thank you all the speakers, and I would also like to thank all the delegates who joined this meeting and made these sessions very motivating and encouraging for all of us. As well, a special thanks to my colleagues, my counterparts from the marketing and sales, Mr. Om Prakash, Mr. Pona, then Gita Shri, Anjana.
Sorry.
Yeah, and Dr.
you,
Pushmita, are you still there? Yeah, we lost you. Yeah,
Yes, something
because that was something very exciting which was going on, and then suddenly when it came to the end of the discussion about whom to treat and when to treat, then suddenly we. Yeah, so if you are there, yeah, just share for the final comments from your side about those questions that you had asked. I'll just share it again.
Last slide.
Yeah. Just let me share the slide. This one, yeah. Over to you, ma'am.
Now, whom to start therapy of CLL? A prognostic scoring system in CLL and that of asymptomatic early stage disease has grouped the CLL patient into three: high, intermediate, and low. They have included the parameters like unmutated IGHV, T53 mutation, age more than 65, palpable lymphadenopathy, absolute lymphocyte count more than 15,000, and high beta-2 microglobulin level that is more than 3.5 milligram per liter. So, and it is also noted that, or seen but demonstrated that the high risk group patients of CLL have more propensity for the disease progression, and they require therapy. So to conclude that high risk patients should be given treatment at the diagnosis only, not to delay, because they have a high chance. About 70% of patient in high risk group have a chance for disease progression. So we can start therapy of CLL in this type of high risk group patient. Now, when to start? And now this is for those patients who are in lower risk group. Those do not have these high risk parameters. In those patients, as already discussed or explained by Jivan sir, the indications for CLL therapy, that is short doubling time of lymphocytosis that is less than 6 months, or increase in lymphocyte count by 50% in 2 months, rapid increase in organomegalies, autoimmune cytopenias not responding to steroid, and the patients with severe intolerable B symptoms, etc. They should be given therapy if they have such clinical features. Now, what to start? This is the mainstay or the main point of discussions of this webinar. It is vividly described or explained by Dr. Devmanlo. Only I want to point out few selective points, like the traditional options of therapy for CLL was bendamustine rituximab combination, FCRs, and there are many novel drugs like BTK inhibitors, venetoclax, and other newer CD20 monoclonal antibodies. Now, different trials have demonstrated that BTK inhibitors are better options for BR or FCR. Again, BTK inhibitors are not inferior to venetoclax rituximab combination. Now, coming to BTK inhibitors. The most common BTK inhibitors are still in use are ibrutinib and acalabrutinib. Among these two, acalabrutinib, being a selective covalent BTK inhibitor, has much lesser side effects than ibrutinib, like that of hypertension, bleeding, rashes, etc. So to conclude, BTK inhibitor, preferably acalabrutinib, is can be used in naive CLL patient, not only in relapsed refractory CLL. Next, thank you.
Thank you, ma'am. Thank you for that wonderful talk. Thanks for rejoining again because that was something which we were missing, but then you finally completed it. So I was just in the process of delivering the vote of thanks, which Mr. Om had asked after we had waited and we had taken a few questions before you could join from the delegates. So, we have a lot of delegates who are watching this, and, this is something, a very nice talk, which we had in the last couple of 1.5 hours, and that was truly enriching and very well. I am very much sure that this would have added to the scientific knowledge of the delegates who are watching us on this platform, this which has been also been streamed on the YouTube channel. So thank you everyone for joining. And with this, this activity always keeps us motivated, and we'll come up with such activities more and more often as and when we could do it. And your participation in such programs have always been encouraging to all of us. So from the House of Samarth,
Thank you.
I take this privilege to thank all of the speakers, all of the delegates, and all my team colleagues from marketing and sales who could make all of this program possible. Thank you, everyone, and have a great day ahead. Good night.
Good
We
night.
can close for that.